has not only gained tremendous experience, knowledge, and shows great judgment, but he's also seen the dark side and is currently going through the match for Trauma Critical Care Fellowship. He has been involved while a resident here in multiple committees, both department-wide and hospital-wide committees, and really various areas, including being the surgical representative to the resident council for several years. He's been involved in research, primarily on the trauma critical care side of things. He's presented his research at AAST, the American College of Surgeons TQIP meeting, as well as regionally. And as an undergraduate, he published a number of papers in chemistry journals, most of which I can't even understand the titles of those papers, but he was quite accomplished in research and his background. And today he's going to talk to us about one of his passions and one of Dr. Sixta's passions, which is transfusion. Max?
Hopefully I did that right. Good morning. So before we actually get into the meat of this presentation, I wanted to talk a little bit about the pathophysiology of shock and hemorrhagic shock. So we're going to do a little basic science review before we get into the literature. So for all patients that present right now to level 1 trauma centers in the United States, hemorrhage and profound neurologic injury are the two preventable, most common causes of death that we see. So hemorrhagic shock, as many of you know, really only presents, or hemorrhage presents as shock once you hit about a 30 to 40% blood loss in terms of your total circulatory volume. And once you get to that point, anaerobic respiration takes over, you develop an acidosis, et cetera, and that can end to multi-organ failure. The actual blood loss itself, we all know, is made up of red cells, plasma, and platelets. Red cells are the oxygen carrying capacity of blood, with hemoglobin as the central unit. Plasma, which is your clotting cascade containing, importantly, but including other things, fibrinogen, which helps create fibrin for a fibrin clot, and platelets, which generate your platelet plug. But in terms of bleeding, you only have 10 grams of circulating fibrinogen. And if you centrifuge down all of your platelets and siphoned off the supernatant, you'd be left with only 10 cc's of solid platelets at the bottom of a vial. That's about 1.25 trillion platelets, but if you think about that in terms of a volume, it's not very many. When you bleed 30 to 40% of your blood volume and present in shock, that takes over 24 hours to generate that much fibrinogen, and it takes days to regenerate those platelets. When your actual level of clotting factors hits 30 to 40%, you are guaranteed to have clinical coagulopathy, and how you resuscitate those patients actually makes a difference, because dilution makes that problem worse, and that includes dilution by giving too many red cells, which doesn't contain plasma or platelets. In terms of the clotting cascade that we all know, these factors, except for really the protein C, protein S contingent, were discovered between the late 1800s and the 1960s. And with the discovery of this, along with PT and PTT, we eventually worked on our understanding of coagulopathy. But when we talk about enzyme kinetics, which I'll explain why that's important in a second, two areas of focus are on your 10A's complex, which is the combination of 10A and 5A, which produces thrombin, and the conversion of fibrinogen to fibrin by thrombin. So again, we talked about fibrin being the source of your actual fibrin clot. So as we proceed with this lactic acidosis and hypothermia associated with shock, your 10A's complex actually has significantly reduced activity the more acidotic you are. And we've all seen patients show up with hemorrhagic shock with a pH of anywhere from 7.4 down to 6.8. But you also get metabolic degradation of fibrinogen. In terms of the hypothermia that's associated with shock, your coagulation factors have 50% activity at 30 degrees Celsius. And your platelet activation through this von Willebrand factor GP1B9 complex, which we'll talk a little bit about later in a different context, actually fails at 30 degrees Celsius. So when you look at those two things together, acidosis and hypothermia as components of shock, they both obviously lead to decreased clotting function and coagulopathy. So this is the lethal bloody triad that we all know about, or the bloody triad of death. And it is the end result of uncontrolled hemorrhage and non-corrected coagulopathy. This is what you want to avoid, because this is bad. Acute coagulopathy of trauma represents a category of patients that show up either with clinical coagulopathy or coagulopathy on studies such as thromboelastography or conventional studies like PT and PTT, not including patients that show up anticoagulated. So in those patients, it's about 30% of trauma patients have some abnormality. There's an increased risk of mortality, generally between 25 and 50% compared to 4 to 11% in patients who do not show up with acute coagulopathy of trauma. So that's a significant portion of our patients. The whole current mantra of transfusion is restoring circulating volume. Some of that is red cells for oxygen carrying capacity, but ultimately it's to restore your circulating volume and correct the hypothermia. When you then add that with prompt control of hemorrhage in a surgical setting, you're able to reverse acidosis and restore physiologic coagulation. That's the overall concept. It's very straightforward. Today, we do this by mimicking whole blood with a packed red cell plasma and platelet ratio of what's known as 1 to 1 to 1, meaning equal portions of each. We emphasize the low crystalloid volume. We use early massive transfusion, where the blood comes in this ratio in a cooler, and you persist and transfuse until you have surgical control of bleeding. And then after that, we use viscoelastic testing, or thromboelastography, to provide a product-specific post-transfusion resuscitation. So that's, or post-massive transfusion resuscitation. So that's what we do right now. But if you look back through history, that's not always what we did. And as we're going to talk about, it is very well not what we're going to continue doing. So now starts the actual part of this talk, which is the modern transfusion practices in hemorrhagic shock. Is history repeating itself? So before 1900, treatment of hemorrhagic shock and postpartum hemorrhage with massive transfusion, or transfusion in general, actually, was fairly common. But it carried a mortality rate of 50%. There was no ABO blood typing, so transfusions were just performed, and if you died, you died, and if you lived, you lived. But postpartum hemorrhage in the literature before 1900 and hemorrhage from trauma was almost universally fatal. So having a 50% mortality compared to 100% was pretty good. Karl Landsteiner in 1900 identified ABO blood grouping, and in 1939 identified the rhesus factor. But 7 years after he discovered this, Ludwig Hectoen in Europe actually recommended transfusion based off of cross-matching. That had not even been done for 7 years. And Ruben Ottenberg in New York was the first to actually perform the first cross-match transfusion. He also identified the Mendelian genetics of universal O donorship. But we went into World War I actually in a pretty good position. So we have the ability to do direct whole blood transfusion. You plug the vein of one soldier into the vein of the other soldier. All of the blood that was transfused ideally was cross-matched at that time. They knew the blood types of the soldiers, and they could do that very successfully. Citrate had been identified in 1908 before the war started, so they could anticoagulate their circuits. And actually, this is the first time cold whole blood was performed, or used as a transfusate. So less wounded soldiers were bled into flasks with citrate that was then refrigerated and used to transfuse soldiers later on. And it was very successful. But at the end of the war in 1918, Roos and Wilson published a series of papers looking at restoration of blood pressure with plasma only. And they thought that a lower viscosity fluid would lead to more brisk circulation. They thought that that was the actual problem. So after a second study was published in the British Medical Journal showing the same thing, the aftertaste of the first successful massive whole blood transfusion campaign was left with animal studies endorsing plasma resuscitation. In 1940, the entire blood banking and blood collection world changed because Edward Cohn developed cold ethanol fractionation. This is the first time that we were able to actually isolate albumin in addition to red cells and plasma. And interestingly enough, when we entered into Pearl Harbor, we entered into World War II, and Pearl Harbor was, of course, the start of that. Isidore Ravine, who was a military surgeon in Philadelphia, took the first 40 bottles of albumin from Philadelphia to Pearl Harbor and resuscitated the victims there with albumin. We then proceed to our war in Europe. Flights to Europe aren't that common. There was concern over refrigerating whole blood, and they didn't want to send over warm blood because of infectious risk. So based on the studies coming out of World War I, we pretty much used plasma and albumin. Once the victims or combat casualties had been evacuated far enough back, they were given blood. But really, in addition to hypotensive resuscitation, which Beecher described as an increased mortality when patients were resuscitated to a normal systolic blood pressure, and he found this out during World War II. When their MAP hit 65 and their systolic was greater than 90, they would bleed, and their mortality would increase, and this was, again, redemonstrated 50 years later in animal studies. Plasma and albumin with blood on the back end of the resuscitation with hypotensive resuscitation led to a lot of coagulopathy. Keeping the patients hypotensive actually had no benefit in this setting. And it wasn't until 1942 when in North Africa, U.S. and British forces were working together that the surgeons compared notes, and the British surgeons said, well, we're using whole blood. We don't have any coagulopathy. So within a year, we were sending over cold whole blood by the plane load to Europe and putting it into these refrigerated 1,000-pint trucks and driving it all over Europe. And some papers have said that we've actually transfused 800,000 units of cold whole blood during World War II. In 1948, thromboelastography was developed, which we're not going to spend that much time talking about, but this surprisingly because I love it. But this technology was actually duplicated in the United States just after this time for cardiac surgery, and it didn't catch on in the trauma world for 50 or 60 more years. But just after this, we entered into the Korean War and had a successful whole blood transfusion campaign there with no transfusion reactions recorded. We then enter into the Vietnam conflict, and in 1964, 3 different researchers simultaneously discovered the coagulation cascade in PT and PTT. But again, we relied heavily on whole blood and crystalloid. Actually, lactated ringers was more available now than ever before, and even more available and present than saline. We also had packed red blood cells in plasma. Because of cold ethanol fractionation, we now had additional modes of transfusion. And between 1967 and 1969, we had transfused over 1/3 products of cold whole blood to 100 surgical teams. But the backbone of the resuscitation, as you can see in this picture, with OR attire that I couldn't even imagine getting into the operating room with now, and a bunch of crystalloid was crystalloid. They gave these guys water in the field. It was salt water in the field and salt water in the hospital, and then they transfused them on the tail end. Most of that was because of availability, but there was whole blood. It just was not as available as packed red cells and plasma. As you can imagine, there was a lot of acute pulmonary edema. So they looked at the experience. This is Simmons and colleagues who really developed a lot of work out of the Vietnam experience. They looked and saw that even though they had improved early survival compared to previous conflicts, and they had improvement in early organ failure rates, so patients weren't getting renal failure, they saw this phenomenon called Da Nang lung, which is essentially ARDS. And as sicker patients were actually surviving to get to the hospital because of helicopter medevac, they ended up seeing an increase in late mortality associated with pulmonary complications. And if you read this paper, the top 3 causes of ARDS were listed as wound shock and chest trauma. And all the way at the end, the last possible cause in their mind was over-resuscitation with crystalloid. So they had an idea that it was part of the problem. They just didn't understand to what degree. The same group in 1969 actually published the first demonstration of acute coagulopathy of trauma. So they found an early hypercoagulable state. Patients who came in with shock, defined as less than 60 millimeters of mercury systolic blood pressure, acidosis, and lactatemia, had a change in their PT and PTT. They saw an abnormality in PT and PTT in patients that showed up without shock. And they found a high degree of patients that had hyperfibrinolysis, or breakdown of their fibrin clot, that was not associated with their shock state. And some of this may sound familiar to a lot of you because in the last 10 years, all of this has been redemonstrated in studies 10 to 20 times the size with thromboelastography in our current population. So these guys were right. But also in this paper, in a small subset, they did a head-to-head comparison of fresh whole blood versus cold whole blood and found equal outcomes. So leaving the Vietnam War in the 1970s, there was a sudden shift in resuscitation strategy. And instead of focusing on prevention of early coagulopathy, which was the concept of whole blood in World War II, and even whole blood in the Vietnam War, we focused on restoration of flow in general and maximizing perfusion. So this was actually done through crystalloid and packed red cells, mostly. The use of FFP was admonished, which we're going to talk about why, for a lot of this time between 1970 and the 1990s. And we're going to sort of talk about the studies that led to that. So the Shires group, originally out of Columbia, looked at fluid resuscitation and hemorrhagic shock. There were multiple papers, 4, 5, 6 papers. This is just 2 of them that we're going to talk about. But these 2 papers, which we're going to talk about, what they did and how they did it, plus an additional paper in 1985 that had 18 patients resuscitated with crystalloid only, no control group, and no blood products, was actually the foundation for 2 liters of fluid that was recommended by ATLS. So just so you have an idea of how influential this was. So they took iodine and sulfur colloid and radioactive sulfur and tagged red cells, albumin, the interstitium, extracellular space, etc. And they measured those volumes in dogs. They then induced a hemorrhagic insult. They bled the dogs and left them in shock for 2 hours. Then they measured those volumes after 2 hours. And what they found was that the extracellular fluid had migrated into the intravascular space, which is not surprising. It's a compensatory mechanism. It makes sense. But then they transfused that blood back to the dogs. cc per cc, not one unaccounted for. And they found that even though they gave the dogs their blood back and their shock got a little bit better, they still had an extracellular volume deficit. They then repeated those studies, bled the dogs again, different dogs, and returned that blood either alone, with plasma additive, or with Ringer's lactate. And what they found was that the dogs that got Ringer's lactate survived the longest. That was the whole finding. If you gave dogs a whole blood transfusion, that's what that is, followed by Ringer's lactate, the dogs did better. But, again, they measured those spaces and found that the extracellular fluid deficit was still there, and believed that the ongoing shock state and milieu of shock and inflammation was because of that deficit. About 10 years later, they published another study, which we're going to talk about, but they recommended 1 to 2 liters of LR until whole blood is available. All right? So that was in their paper. Give whole blood, give crystalloid first. In their second paper, they said the same thing. Give LR, it's going to replace the extracellular fluid. But the end of both papers, the closing commentary states that the extracellular fluid deficit contributes to ongoing shock state, and that the crystalloid infusion appears to reduce the need for whole blood transfusion. So they felt that a fluid challenge actually reduced your need for any product transfusion. And that sort of set the tone going forward. 10 years later, they then did another study and showed that larger crystalloid volumes with higher fluid rate led to increased survival in dogs. In Detroit, at Wayne State University, Harper Hospital, they had a hemorrhagic shock model, Lucas and Ledgerwood, very well known in the trauma literature, had 22 dogs. They then bled them. They resuscitated them with balanced electrolyte solution, which was Ringer's lactate. They then gave all of the dogs packed red cells, but they were diluted in Ringer's lactate, and then gave half the dogs plasma, and then didn't give the other half of the dogs plasma. But at the time, the recommended plasma transfusion ratio was 6 to 1. So they got this little spittle of plasma for the dogs that got plasma. When they checked their circulating coagulation factor levels, they saw no difference. So they said, well, there's a transfusion risk associated with transfusion, and this doesn't do anything, so you shouldn't give anyone FFP. That was the mantra that was echoed by several papers. There was another paper just like this one that showed that after a whole blood transfusion, if you gave FFP, that it didn't change their circulating factor levels, so you shouldn't give FFP. The fact that there was a whole blood transfusion was kind of missed in the interpretation of that data. But if you look at when this data was coming out in the 1980s, this was the era of the golden hour of trauma. This was the hot topic, right? So 80% of trauma patients were dying. There's the immediate death group and the death within hours. So your chances to save people are greatest when you intervene on the people in the late end of immediately and into the hours. That's the people that we want to try to grab, right? Dr. Don Trunke was traveling across the country advocating for right person, right place, right time. We need the sickest people at level 1 trauma centers as fast as they can get there. And you had Dr. Schwab and Dr. Rotundo publishing on damage control surgery, sacrificing anatomy for physiology, controlling bleeding, controlling contamination, and resuscitating after a retreat to the ICU. So a dog that was bled for 2 hours is not analogous to the trauma patient showing up in the late 80s and into the 90s. These people were getting there sooner, and they were getting shorter operations with more resuscitation. In addition to that, whole blood, which was used in a lot of these studies, was almost not even available. because component therapy was so beneficial for the medical community as a whole. Thrombocytopenic patients got their platelets, anemic patients got their red cells, that hemorrhagic shock resuscitation wasn't really in the forefront of the blood bank's mind, which is understandable. There are a lot of patients that need a lot of things. So for 20 years, this concept of optimizing cardiac output, optimizing perfusion, replacing red cell mass as a replacement for deficient oxygen delivery, that was the thing. That's what was done. In the early 90s, actually, interestingly enough, in my alma mater, 2 papers out of a series were published that showed that if you resuscitated animals after you bled them with only crystalloid, their cardiac output improved and their markers of perfusion got better, but the actual end organ perfusion, as determined by indocyanine green studies and actual direct flow measurement, didn't get better. So you can give them all the crystalloid in the world, but the overall inflammatory shock process was not getting better, and their organ perfusion was not improved. Same thing with cardiac output. You could push your cardiac output as high as you wanted. Supraphysiologic in some cases was being recommended. Put a swan in them, push them with fluid. It doesn't make a difference. Secondary abdominal compartment syndrome was everywhere. This is a review article that was published in 2001. It looked at 1995 through 2001 out of Denver. And they actually have a table that shows you that these patients were getting 50 liters of crystalloid in 24 hours. None of these patients had intra-abdominal injuries. None of these patients had a laparotomy. These were patients that had hemorrhagic shock from extremity injuries, hemorrhagic shock from other diatheses, and they were transfused in ratios all over the place. But they got tons of fluid, sometimes more than 4 or 5 times their actual circulating blood volume in crystalloid. And the mortality was over 50%. And ARDS was the same issue. So in the mid to late 90s, there were several publications, but one of them that I came across was this, actually a panel discussion from one of the International Resuscitation Conferences in 1996. And Dr. Tischerman, who's currently at Shock Trauma, and Dr. Peitzman from Pitt were actually quoted as emphasizing crystalloid-restricted resuscitation. They said, we don't know what we're going to do. Obviously, we want something to separate or to substitute blood, because if the risk of blood is, transfusion-related reactions, they said, plasma has been shown to be bad in resuscitation, but we're giving people ARDS and we're causing abdominal compartment syndrome. We have to do something else. And they also talked about hypotensive resuscitation, which was described in 1940 and wasn't obviously being done because while patients were in the operating room, they were getting bolused with crystalloid with a Swan-Ganz catheter in, trying to push their cardiac output. So this was sort of a call for reform. Unexpectedly, we'd have a great opportunity to test this as we entered into Afghanistan, followed by Iraq in 2001. So the military heeded the warning from civilian trauma surgeons, and many of the military surgeons were also civilian trauma surgeons, and understood the importance of a low crystalloid resuscitation. Early in the war, they fell back and leaned on the backbone of resuscitation for 50 years prior, or 60 years prior, and even longer, and used whole blood. They found that fresh whole blood was incredibly beneficial. But even though the military represents a walking blood bank, where young, healthy, screened soldiers are able to provide direct transfusion or even indirect transfusion, it still wasn't as available as component therapy, which is what the blood banks are putting forward. So they wanted to come up with the perfect alternative to whole blood. And they found that in component therapy. So right around the time, actually, that Bill Johnson stepped foot in Iraq, and that's who this picture is, they were ready to publish their results. So in 2007, Borgman and colleagues published their results on 246 soldiers, and these are pretty remarkable results. They split them into 3 groups in terms of their retrospective review, those that had gotten a low, middle, and high ratio of FFP to red cells. So the 1 to 8 group, 1 to 1 to 2.5, and then 1 to 1.4. So these are the 1 to 1. For every unit of red cells, you get a unit of FFP. In the 1 to 8 group, for every unit of red cells, you get 8 units of FFP. What they found was that as you progressed from low to high, remember this is 1-to-1 resuscitation, so as you progress from low to high ratio of resuscitation, your mortality from shock decreases significantly. And if you die from your injuries and you received a 1-to-1 resuscitation, your median time of death was 38 hours, which is way outside the window for hemorrhagic shock. No one's dying from bleeding to death at 38 hours, or else you haven't seen a surgeon, right? So likewise, if you look at this table, or this graph, in the low and middle groups, almost nobody died from the other causes of death we see in critically ill patients. But in those that received a 1-to-1 ratio, they survived to get all those other horrible things that we see in patients who are critically ill and get critical care. They survived to get multi-organ failure, die from their pneumonia or their bloodstream infection, from their ARDS, or from their TBI if they didn't have late death from that or early death from that already. So it clearly showed a survival benefit. If you actually control for those who received whole blood, because inevitably part of the transfusion protocol had whole blood, and you exclude those that had bad TBI, their outcomes were still incredible, and saw mortality decreases from the 60% down to the teens, just by manipulating the ratio of transfusion that they got. It wasn't shown in just one study. It was shown in multiple. Here's just a few of them. They studied time to transfusion. They studied fibrinogen and red cell ratio as a surrogate of FFP. They studied platelet ratios, more plasma, more blood, less blood, and they found the same thing across the board. All of these studies showed improved mortality, 1-to-1-to-1 resuscitation. That was in the military, and then they showed it in the civilian trauma population as well. So in this study, it's a retrospective multi-institutional trial, 466 severely injured trauma patients with ISSs in the 20s. They showed Kaplan-Meier curves, hours from death from admission, and days. Both the high FFP and platelet groups, which is the top line, in both categories outperformed all other transfusion ratios. And at all time points, 6 hours, 24 hours, and 30 days, and in terms of ICU outcomes, the high plasma, high platelet ratio patients did better, no question. Then we asked the question, well, and you have to pay attention to these titles and ratios because every study does it a little differently, but plasma, platelets, and red cells, 1-to-1-to-1, compared to plasma, platelets, red cells, 1-to-1-to-2. So giving more blood and less plasma and platelets. So it was a randomized, multi-site clinical trial called a proper trial. 680 patients. They looked at 24 hours, 30-day mortality, and all-cause mortality, and found absolutely no difference. They did subjectively report earlier hemostasis in patients that got 1-to-1-to-1, which actually makes sense because they had a more hemostatic resuscitation with a larger volume of clotting factors. A subset of that group, I find this very interesting, and this actually just came out recently, showed that for every minute that you delay massive transfusion once you call for your cooler, you have an increased risk of mortality by 5% increase in odds ratio per minute. So when you hit 20 minutes, you now have a twofold increased risk of mortality. But not everyone believed 1-to-1-to-1. There were a lot of studies that came out that showed there's a survivor bias, so 1-to-1-to-1 was calculated over 24 hours. Not every patient lived to 24 hours, so not everyone got there. Some patients died within 4 hours. They got a unit of blood, 3 units of plasma. So how are you going to say that 1-to-1-to-1 ratio is really what led them to survival? So 2 studies were designed to look at that from 2 totally different perspectives. One was this debunking the survival bias myth. It was a multi-center prospective cohort study of 600 patients, and they actually calculated the ratios out at incremental times, 6, 12, and 24 hours. And when they compared for mortality and outcomes, they found the same thing, that high FFP to RBC ratios conveyed a survival benefit at all time points. If you take into account the fact that the ratios are not constant, they're never going to be, because you're transfusing these people through sometimes one central line. You give blood first, then you give some FFP, you give some platelets. It's a time-based process. This is the PROMPT study, 905 patients, prospective cohort study, looked at actually using a multivariate time-dependent analysis, which I'm not smart enough to understand exactly how that impacts this process, but from those that I've spoken to that understand this say that it controls for that variation in time, showed that high FFP to RBC ratios confer a survival benefit at 6 hours. They didn't find that at 24 hours, but again, most patients aren't dying from hemorrhagic shock at 24 hours. They're dying in 6 hours. And they actually found an increased mortality as you deviated from that ratio. This is a study that also came out more recently that looked at between 2004 and 2009 patients that received massive transfusion, and they found that through their massive transfusion process, almost all the patients were 1-to-1-to-1 throughout 6, 12, and 24 hours. But over time, their rate of massive transfusion decreased. And what they found was that in the patients that received less than 10 units of blood in 24 hours, if you stuck to 1-to-1-to-1, you were less likely to need to go through an entire massive transfusion. So if we look at this, you kind of have to say to yourself, well, there's a lot of data supporting 1-to-1-to-1, right? That's what we do right now. Low crystalloid volumes. Almost all of these patients receive less than 8 liters of fluid in 24 hours. Most of them receive less than 5. So where do you go from there? It's got improved mortality. It works. We do it all the time. We're comfortable with it. But if you think about it, component therapy came from a desire to replicate whole blood. Part of the issue is that when you look at component therapy, and this is where I'm going to start advocating for whole blood, just so you're aware that that's coming. Component therapy and whole blood, if you combine them head-to-head, component therapy requires administration of more volume. We already know more volume puts us at risk of ARDS and everything else we already talked about. But also, when you go through and look at them head-to-head, you're actually providing an anemic, relatively thrombocytopenic, and technically coagulopathic product. They do have the same amount of fibrinogen, so that's at least one bonus. But it's not the same thing. I will say the benefit of warm whole blood is that one is warm. We already talked about the issue of hypothermia. But if you actually dive into the issues behind whole blood transfusion, a lot of it has to do with the other parts of whole blood transfusion other than whether or not it works. So the storage issue. If you look at storage of whole blood and component therapy, in cold stored red cells, the mean age at the time of transfusion is 27 days in level 1 trauma centers. The maximum survival of those red cells is about 42 days. And when you get towards that 42 days and you're at some outside hospital, they'll actually come and collect your blood and take it to a level 1 trauma center to be transfused in a master transfusion because they know that they're going to consume that product. But we know that there's a reduced capacity to offload oxygen in blood that's been sitting in a bag longer and longer. That's the only purpose of the red cell, really, in this case, is maybe some oncotic pressure, maybe, and reduced capacity to offload oxygen. So that's not ideal. Right now, we have a lot of information on using fresh whole blood, but there have been concerns about storing cold whole blood. And in the level 1 trauma center in the urban environment, that's really what you're going to be looking at is cold whole blood for transfusion. So this is a study that looks at pathogen reduction technology, adding riboflavin and blasting these bags of blood with UV light to kill and intercalate DNA in white cells and reduce your surviving pathogen load. But they compared this blood, cold and warm, with and without this pathogen reduction technology. And what they found is that glucose is an excellent surrogate of metabolic activity. The higher the glucose level in a sample of blood, the less metabolically active the blood is. So you want to attenuate that metabolic activity, which cooling cold whole blood does. So this gray line in all of these is cold. The triangle is representative of the PRT blood, which is not the control and the control. So better than whole blood at room temperature, cold whole blood actually is preserved better in terms of metabolic activity. PT and PTT, because Dr. Giverson doesn't like thromboelastography, shows here that actually you have functioning non-coagulopathic blood out to 21 days when you cool whole blood, whether or not you treat it with PRT or not. If you look at thromboelastography, my favorite thing, you maintain a low R time, you maintain a low K and high angle. These are both thrombin and fibrinogen-based measures, which shows that you have intact clot building ability. Your MA and your clot strength are both factors of the platelet contribution to blood and the strength of the clot that forms. So having a high MA and a high clot strength, it shows you that the platelets are still functional, and that's out to 21 days. So the average red cell that you're giving is 23 days old. This is 21 days old, and it still works. It also attenuates the loss of platelets and platelet function due to aggregation and storage. So if you shake a bag of platelets, they'll aggregate right in the bag. They're nasty little guys. That's all they do is aggregate. That's what they're for, right? It also attenuates the loss of agonist-driven platelet aggregation, which is where ADP in solution causes the platelets to degranulate while they're in the bag. So you get reduction in that as well, so the platelets are ready to go. I'm going to be unbiased, and I'm going to say, however, The reason we don't give cold platelets to anybody is because 50 years ago, they found that when they cooled platelets and transfused them, you had increased expression of this GP1B alpha ligand. And in humans, that will actually bind to a receptor in hepatocytes and in the spleen and cause increased rate of clearance of transfused platelets. So it's not that the platelets don't work when you cool them, it's that you'll sequester them and your circulating platelet volume goes down. The issue with this is that when you cool whole blood, you do have a significant increase in expression of GP1B alpha within 7 days. So theoretically, that can lead to increased sequestration by the liver and spleen. However, the effect that that has on hemorrhagic shock resuscitation has never been studied. In fact, the impact that that has on any coagulopathy has never been studied that I can see within the last reasonable time frame. So especially in our patients, we don't know what that means. Those platelets could be used exactly for what we want them for and not get sequestered on first pass. We don't know. It hasn't been studied. The titer issue is the other problem. We're talking about using, uncross-matched whole blood in patients. You have a risk of transfusion reaction. In World War II, all blood that was transfused was type O, regardless of the recipient. In a study looking at non-O recipients, meaning A, B, and AB patients, they noticed in 265 patients minor transfusion reactions. All three of those donors had anti-A and anti-B IgM titers, or antibody titers, greater than 500. The reactions were not clinically significant. Nothing happened to those people. They had a little bit of dark urine. They had a fever. They were fine. But one reaction did occur in someone who had an anti-A, anti-B IgM titer of 8,000. It made the researchers a little bit concerned, reasonably, because that could have been much worse. And so they instituted a low titer policy, that you could only be an O uncross-matched donor if you had low titered whole blood, which I think is reasonable. In the Korean War, they used this transfusion policy and had no reactions. In Vietnam, the reaction rate for any transfusion reaction was listed at 1 in 10,000, and they had no documented, outside of improper cross-matching, which did happen for type-specific blood. They found no reactions for patients that were getting type O blood that were clinically significant. No major hemolytic reactions. So the U.S., just to be totally clear, currently in the military does not allow for uncross-matched, untitered O blood transfusion, except for in austere environments or when blood products are not available. So that's permitted, whatever you got to do to keep the soldiers alive, which is appropriate. But they do allow for non-titered platelets and plasma. And we at this institution use A-positive plasma all the time as a universal donor, although it's low titer. So this is being done all the time. People are getting, it's not the issue of titers in the red cells, it's the issue of the plasma. So we currently give people all the time plasma and platelets that are sitting in solvent that contains anti-A and anti-B IgM. In other NATO countries, they use whatever they want. In our experience, transfusing patients with whole blood, this is a prospective study, looked at 61 Marines, and they found appropriate arrested coagulopathy, no adverse reactions in patients who received direct whole blood transfusion, either type-specific or O, that was not titered, but it were direct transfusions and found to be safe. In the civilian population, there are only a few institutions that actually do this. One of them is Pitt, which is not far away. In 47 cold whole blood recipients in trauma, they used leuko-reduced platelet-sparing filters. So basically it removes all your white cells, should help alleviate some of that burden for immunogenicity, but also takes out 20% of your platelets, a lot better than a non-platelet-sparing filter, which takes out all of them. And what they found is that in the 47 patients, 30 of them were non-O recipients. They measure all of these patients for hemolysis labs because they're concerned about transfusing anti-A and anti-B IgM antibodies. So what they found is that there was a minor drop in haptoglobin levels. So haptoglobin is a molecule in the blood. It binds hemoglobin. Its drop and removal from circulation is indicative of hemolysis or a hemolytic transfusion reaction. They saw a drop in 7 out of 30 patients, but none of them had any adverse reaction. And that may affect them in terms of receipt of blood down the line, but they didn't have a major clinically significant transfusion reaction. They published the same thing with O-positive donors and recipients of all blood types. They do not give O-positive to childbearing age women. It's only to men. and women outside of childbearing age, and they had no adverse reactions there as well. So it seems relatively safe. Transfusion-transmitted diseases are an issue in the military, more so because they use fresh whole blood, but we can screen cold whole blood. That's the purpose of storing it. Then the question of feasibility and efficacy. So you probably would not believe this if I told this to you, but these are slides from the actual Trauma, Hemostasis, and Oxygenation Research Network in 2013, actually just before I started residency here. And believe it or not, if you have a massive bleeding event on a Royal Caribbean Cruise Line ship, you can get a massive transfusion with whole blood. Believe it or not, on a cruise ship in the middle of the ocean, you can get whole blood. They have this little kit that they open up. There's some collection bags in it. There's a doctor's kit. I don't really know what's in there. They've got some blood collection tubes, a little rapid HIV screening kit, and a bunch of Eldon cards so that they can basically determine your blood type and determine the blood type of donors. They have an entire process. They prepare you. Obviously, that's important. Preparation is key. Get some consent, which is the longest consent I've ever seen. It's actually another slide which I didn't include. And they develop your blood group or determine your blood group. And then they identify your donors. So they start with family members. They go to sexual partners, which could be few or many, depending on how much fun you're having on your cruise. They will look at guests who are blood donors with or without cards. They look at medical team members, crew, whatever. And they determine who's going to be your donor. They've done this at the time. They've done it with more people since then, but I didn't have access to those slides, with 37 people in that 36-month time span. Some of them were guests, some of them were crew, some of them were traumatic injury. One report was from a guy who had a massive GI bleed. Deaths, 5, all of them from presenting pathophysiology. None of them died from a transfusion reaction. 4 of them were lost to follow-up. Seroconversion in terms of change in your actual antibody profile as well as transfusion-related diseases was 0. And 1 transfusion allergic reaction that was very mild, and the patient recovered with only supportive care. So they're doing it, and it works. In the military, most of the data is on fresh whole blood, a retrospective review of 100 fresh whole blood recipients versus 254 component therapy patients that presented with a similar level of injury. And what they found is that the total number of red cells, if you looked at whole blood versus product, didn't really change. Some of the patients with fresh whole blood also got red cells in component therapy, but they required less. And actually, the total volume transfused was less. The anticoagulant and additive volume was less. We know volume is bad. They survived. The actual survival in 24 hours and 30 days was better. There was a slight increase in DVT and PE that was not prospectively screened for, so we don't really know how clinically significant that was, and some more renal failure, same issue. But that was actually shown to be overall effective. And actually, both 1-to-1 transfusion and fresh whole blood had a 12-fold increased risk of survival when you looked at odds ratios. We look at a retrospective review of 394 patients who got component therapy and 94 with whole blood. The reason that they get component therapy with whole blood is the indication for whole blood. A lot of times in the military is failure to reverse your coagulopathy with component therapy. The fresh whole blood patients actually were sicker, higher ISS, they had lower systolic blood pressure, higher respiratory rate, and actually it significantly reduced their odds ratio for death if they got fresh whole blood and they had no transfusion reactions. It's so effective in the military, which is really the only place we have done this on a large scale. Even in the civilian populations, there's no data that compares component therapy head-to-head with fresh whole blood or cold whole blood yet. But in their tactical combat casualty care recommendations, whole blood is actually listed as the #1 choice resuscitation product in the military. That's cross-matched or otherwise. That's followed by 1-to-1-to-1 RBC, plasma, and platelets. I don't want to talk about how I feel about Hexten, but I think head-of-starch is bad, but it's on there. But actually, liquid or thawed plasma or reconstituted dry plasma, which has been in existence for like 90 years, is also on that list, ahead of crystalloid and everything else. So whole blood has made it to the top of the military's list. They're transfusing more people than we could ever get in a head-to-head comparison. So as a conclusion, 1-to-1-to-1 confers a mortality benefit. I think we've beat that horse to death. Fresh whole blood, type-specific and low titer O, is relatively safe, at least according to the military data. Cold storage yields a functional product. The blood still clots. The platelets still work, except maybe that platelet sequestration issue, which is yet to be determined. Risk of hemolysis or risk of hemolytic transfusion reaction appears to be low so long as you use low-titered blood in cold whole blood in the civilian setting. And fresh whole blood in combat has been associated with a survival benefit. There are several other papers I didn't include, but you saw it in a few of those there. So I think the bottom line is that we should be using whole blood. Everyone knows that replicating the original is never as good as the original. The only reason we use 1:1:1 is because it mimics whole blood. So there's something in using whole blood to transfuse these patients, at least in the initial phase. And besides that, if the Royal Caribbean Cruise Line can do it, we can too. That's all. Thank you.
That was really terrific. The amount of work you put into it is quite evident. We'll take questions from the audience. Dr. Conway?
Max, I was going to say that was incredible. That was great. You could take care of me anytime.
Thank you.
I hope not to be on that cruise
What
ship.
kind of transfusion do you want if you need one?
Well, that's what I mean. I guess line Max up next to me and just hook us up. I mean, if you're type O, is that the ultimate? I mean, it is funny. You were leading us down a path, and I understood. You did a great job. You're like a really good teacher. I didn't even realize it. I'm complimenting Max. I hope I get to compliment you guys down the road. But that I kind of understood where you were going. It seemed like you were, progressing to what your end result is. Would that be the ultimate thing, just to be able to transfuse directly? It's warm blood. It's not cold. There's no platelet issues. You're getting everything you want.
So the issue is that the military has that benefit because they just say, hey, come over here. You're going to donate blood. We don't really necessarily have that here.
We have a residency group.
Yeah, we do. But they have to work, and then they have to drink juice after they donate, and that takes them out of the working pool, and then that's a whole problem. But I don't necessarily think warm whole blood is a viable option here. Plus, I'm not sure that the FDA or the American Association of Blood Banks would ever let that happen, not from a monetary or any other reason that it can't be monitored. And so the safest option, I think, is to give cold whole blood that's low titer. You can screen it for pathogens. It's probably the best option we've got. It's never going to be as good as warm whole blood, but the issue with it is that it's cold. And, for every hour that you're operating on someone, their temperature drops at least 1 degree Celsius. So we abbreviate surgery, but we're going to give them cold whole blood. I think that's really one of the big issues. I don't know. I think it sounds very promising. Obviously, warm whole blood would be perfect. But right now in San Antonio, actually, they're developing a multi-institutional trial to look at cold whole blood, actually pre-hospital, just to get them to that 90 systolic. Someone's bleeding, obviously, and they're in the 60s. Just give them 1 unit of cold whole blood in the field, see what happens when they get there, transfusing them in the trauma bay and in the operating room. So, plus Pitt is developing a ton of data right now. They're using it up to 4 units in their massive transfusion packs. So we'll see.
Dr. Takalis?
Max, first I wanted to say the content was outstanding.
Thanks.
But equally important was the way you presented this information. You did not sit there and read slides. You told a story. And I've only seen that in very mature attendings out on the circuit. I've seen some mature attendings in national meetings that still don't know how to do that. We've all seen that. But you kept our attention on what could be a very dry topic. It was really an excellent presentation.
Thank you.
In both ways.
Thank you very much.
Max, what do you think the impact would be on availability of blood through our various regional blood banks if we went to a cold whole blood? Is that going to take away component therapy for those patients who need component therapy? I don't actually have any idea of what we use in massive transfusion or transfusion of trauma patients or massively bleeding patients versus the community patients who need the component therapy. Do you have any idea about?
So I don't have those
impact?
ratios. I'm sure we can get them. Actually, Dr. Sixter probably has those numbers because she's on the transfusion committee. But I think it would obviously take away from the volume of patients that need uncross-matched component products. But most of those patients actually, in my opinion, I don't know, anecdotally speaking, usually required type-specific products. You have thrombocytopenia, you need platelets before we put your port in or whatever, and an anemia. So I think for the people that are going to need uncross-matched product, I don't think this is something you can implement in every trauma center, level 2, level 3, necessarily, because they're not going to use it fast enough. you'd have to have a similar situation where, if you're getting out to 10 days, someone comes and picks up your blood and takes it somewhere else where they're going to use it. That's the limitation as well. Although a 21-day shelf life is a lot better than we thought. Some people say it's actually good out to 34 days, but I couldn't find that data.
Yeah, excellent job, Max. Just a comment on when, Proper was being formulated. We had already lost our equipoise to do anything other than a 1-to-1 or 1-to-2. So a 1-to-3 or 1-to-4, other ratios weren't able to be studied prospectively. What is there any? You had mentioned the platelet problem in whole blood. Mm-hmm. How would you propose that be studied? And is anybody studying it now? You said there was no data on it yet, but
so I would imagine that data is going to come out of Pitt and maybe St. Louis, if I had to guess, because that's where cold whole blood is being used the most, and they run tags on their patients. That's really where you'd find it in terms of whether or not once you transfuse them, they had appropriate changes in their MA and clot strength and with platelet mapping. There have been studies that looked at using synthetic cold whole blood, which is a weird way of saying whole blood that's been run through a platelet and leukoreduction filter that doesn't have platelets, and then they give platelets with it, and that's shown promise, but it kind of removes the benefit of giving, whole blood, which is that you just throw a bag up.
One thing you did mention that I think you mentioned a little bit about freeze-dried plasma. Mm-hmm. That's not available in the United States,
right?
And it's available in a lot of other places. And just so you know, there was some movement here to try to, rather than do that, administer 4-factor PCCs in pre-hospital setting. We tried to do that a year ago, and the company chose not to fund that. So
I don't know. Plasma is very interesting when you go through all this literature. There's a lot of discussion about whether or not when you're giving 1-to-1-to-1, you should start with a certain product. And there is some evidence to support starting with plasma for two reasons. One is it restores clotting factors. The other one is that in hemorrhagic and septic shock, it's been shown in animal models to reduce the catecholamine-related effects of that shock state, almost as like a balanced, tamping of that response. So I could see the benefit of I don't know about the 4-factor PCC, but lyophilized plasma. The French were doing that in I think in 1939.
And maybe reduce the use of pack cells if you started with plasma, right?
Yeah.
Dr. Sixta.
Phenomenal, Dr. Braverman. I gave a similar, they blew mine out of the water. I gave a similar kind of talk in fellowship, and it was just phenomenal. I think the research, if anybody's ever tried to research some of the stuff in the 70s and 80s, it's a lot of work to go back and get these articles. You can't just pull them off of PubMed, so really good job. As far as a whole blood, it is available in very small aliquots. I believe the neonate population and they have a very small, for the NICU, not the NCC, but the NICU. And we did discuss it a couple years ago. I think there's a lot of centers that are now using it. It would be, I think Dr. Warner is stuck in a horrendous code from what I hear, but it would be nice to get her input because they are using it at Pitt, and I don't doubt that they're studying that. I don't know, Dr. Weinberger, were they using it at Shock? No. So it may be something worth, our blood bank is, and our hematologists they've been very supportive over the past since I've been here, and I know there's maybe a change of leadership down there, but they've been really wonderful working with us, and so it may be something to revisit. And I'll bring that up to Mike Healy next time what he thinks about it. And I don't know that we have a tremendous volume, but if we can get at least some of it, I think in our massive transfusions, Dr. Folda said, he was kind of commenting over here, I think we'd be using less volume, especially in our, not all the time, but when we're using a tremendous amount of volume, we'd probably be much more beneficial to our patients, and I believe we could probably use that volume considering our amount of penetrating trauma that we're seeing now.
And we do have some of our folks from blood bank and transfusion medicine. You folks are welcome to comment or ask a question as well. Dr. Mendanzi.
Yeah. In the early 80s when I started my practice and country doesn't exist anymore, I had witnessed many cases in my obstetrical colleague population, just direct transfusion from soldiers who are easily available. And there was a few cases at DIC that time that only just started figuring out what is a DIC. So, but later on in 80s when HIV came in, so they were not widespread. Transfusion at DIC level increased. So ultimately, most likely it will go to that point. We need this introduced widely than it's now. But do you have any projections when you show number one is a whole blood transfusion, then 1:1:1? What the cost of this? Can you break down? Do you know that?
I don't know, because the only place that stratifies that is the military, and the military really, I don't really know that cost is an issue when they do that. I mean, it's the cost of the limitations in the military that lead them to do this is that they don't have products available when they're in remote locations. There's a whole set of journals dedicated to what's called RDCR, which is remote damage control resuscitation, which is using odd combinations of whatever factors you have to transfuse these people, and that's really where a lot of this whole blood direct transfusion comes from. The cost of direct whole blood transfusion is like nothing. They have a little apparatus, they just plug you in. But usually, actually, they drain it into a bag and then give it to someone else, which is how they were doing it in World War I. They have a flask, put it in the flask, take it from the flask, put it in the other person. But the cost for that is very low, especially because they don't need to ship it, they don't need to store it. So in that sense, it's cost effective, but the actual cost I don't know. The components need to be stored. Blood and plasma need to be frozen, and the fresh platelets, only have a certain shelf life and have an infection risk beyond that. So,
thank you. You did an incredible job.
Thank you.
Any other questions or comments from the audience? Dr. Weinberger, then Dr. Conway again. Go ahead. Do you have something about what he just said?
Excellent job, Max. In terms of cryoprecipitate, it's kind of the forgotten stepchild when you talk about transfusion ratios.
Yep.
In your opinion, where do you think cryo fits in the 1:1:1 transfusion?
So in the patients that get large volume 1:1:1 transfusion, like massive transfusion, most of them shouldn't need cryoprecipitate because the solvent of plasma contains cryo. That's what it is. It's you siphon off the solvent and you concentrate that. That's cryoprecipitate. There is a role. Some of these studies actually used it earlier. Some of them didn't use it at all. I think that using thromboelastography is a great way to determine who needs that and who doesn't. You can look at K and angle, and if they have a high K and a low angle, presumably if you've already left them 1:1:1 and their ACT is normal, they are not going to benefit from another unit of plasma. So they'll benefit more from fibrinogen from that standpoint.
I was just going to ask, any role of the synthetic products? Like, is that even out of the
So the
picture?
blood substitutes, I didn't look at for this presentation, but I do know that I've talked to Dr. Sapoli about this many times. And so far, that has not been very successful. It would be perfect if we had something that replicated whole blood and we could give it, but the only blood substitute we have is 1:1:1 right now.
And that's a great question. I had the same question. Dr. Spoli, is there anything out there currently being looked at for, at least, focus has been on oxygen carrying capacity, I suppose, but nothing's really panned out.
Right. Christiana was actually a very important contributor to one very, very negative trial back in the 90s, diasporan cross-linked hemoglobin, and one trial, polyheme, which was done 10 years ago now, that did not meet its non-inferiority mark, and the FDA did not approve it. There is one product available for compassionate use, bovine-based, called Hemopure. It's actually just up the road in Pennsylvania. So we actually had a patient about a year ago that I made the calls and made the arrangements, but we never did need to transfuse her. But it's been a very disappointing journey to get something approved. I gave a lecture on this a few years ago and had some third world folks in the audience, and that's very different. It's very different there. But nothing's been approved in the United States. And there's one available for compassionate use. There's a few things going on now, liposome encapsulated hemoglobin. The problem with it is that are the side effects. And that's why it has to be cross-linked or pyridoxylated or whatever. And we just haven't been able to quite get that right yet.
Anything other than the oxygen carrying component being looked at from a synthetic standpoint, the coagulation factors or platelets or anything like that?
No, not from a purely synthetic standpoint that I can think of.
Max, again, that was terrific. Once again, we spent 100 years plus trying to improve upon nature. Haven't been successful yet entirely. Excellent job. Thank you.
Thank you.
For Department of Surgery members, we're going to follow with a single M&M case. I'd like to get that started within a couple of minutes.
I hope it's exciting. Thank you. Take shit out of here.
Oh, yeah. All right, if you still have conversations ongoing, I'd ask you to take them out of the room. We're going to start our M&M presentation.
All right. Good morning, everyone. Great job, Max. I'll try and be brief. I know we're starting at 8, but this is an M&M. It's a M&M for patient JM. So date of admission was last November. Date of discharge, also the same date of death, was